So thank you for obviously the opening session. Really, really great to get some questions as well. We're obviously now splitting up the rooms. We've got our peds session next door and then our adult session just now. I'd really like to welcome, if I click on, not the kids' party, you know, you're definitely not the wrong one, our adult treatment and research update. So we're really, really fortunate to have Channa again and Clare come and speak. So I am literally doing an introduction and I'm going to hand it over to someone who's far more learned than me to run the session. So a round of applause for Clare.
So welcome, thank you. It's somehow slightly more intimidated than I anticipated it being, but how I envisaged this being was a chat, a conversation, a bit like I would have in clinic with an individual person, updating, really starting at the beginning. I suspect lots of people in the room are very knowledgeable, but I thought it's sensible we just all check our understanding of SMA as we come in, and then where the current treatments are. And then I've put together a few things that I think are current questions about the current treatments as they are before Channa talks about the future. And maybe in questions, there'll be some other topics that come up. So in terms of what is SMA, and I've worded this one very carefully, as a group of genetic diseases that causes the loss of motor neurons. And so when a motor neuron doesn't work well, the signals that need to go from the brains to the muscles can't get there. And as a result, the muscles that are not receiving these messages would shrink over time, affecting the function these muscles would do, be that breathing, swallowing, speaking, or walking. Now, while the most common reason for spinal muscular atrophy is when the gene mutation means there isn't enough survival of motor neuron protein or SMN1 protein present. I think we do just have to remember, just for a minute, there are a group of people living with SMA who don't have a 5q mutation, and therefore, of course, they haven't been able yet to access any of the treatments that we've used to date, although there may be some non-SMN treatments that Channa will talk about. And then this, I think, links really nicely with a very moving story in the introduction about how far we've come, essentially in my lifetime. So it wasn't until, specifically for 5q SMA, 1990, when they realised that the problem was localised somewhere on chromosome 5. So all your DNA is curled up, and then once it's curled up, it's grouped into these kind of, oh, I've got a laser pointer, there we go, into sort of these 6 called as chromosomes, and then they number them, and they worked out at first where it was. And then it was 1995 that they found the gene. And if you can't find the gene, then you can't work out a problem, and then you can't work out a treatment. So that kind of gives us an idea of the time. And of course, I've always thought about, oh, well, we've got the gene, and that's the treatment, but I just thought this morning's reflection was very powerful in that it also allows people to know what's happening just with a blood test, and that's helpful in itself. Not turning it into a GCSE biology lesson, but just so that people talk about carriers, don't they? So in order to have this SMN1 gene that can't work properly, it's okay if you've only got one of them because the other one can kick in. So there needs to be one with a bit of a misprint in from both the mother and the father, which is what people were saying, that you've told you've got a 1 in 4 chance of any other children from that parent having SMA, a 50% chance of their children being carriers. So that was that from the genetic point of view. And again, the only reason not the only reason, it's important to understand, but it wasn't until people could understand the genes and what they did that they could start to think about treatment. So this is the survival of motor neuron protein 1 gene, and normally that gets, so when you called that DNA goes to, it's like the, they call it the blueprint, don't they, the recipe card, tells people how to make protein. There's quite a lot of sort of messing around that goes on in between to get the DNA to the protein. And this gives you the full amount of protein in the first place. There's this backup gene, SMN2, which is almost something that's happened in evolution. It's actually flipped backwards. And it's just not quite right. It's got this one misprint in it that means it makes this sort of slightly smaller protein that's quite unstable. And so it can only make about 10% of the functional protein. So if you get rid of the SMN1 gene and it can't work anymore, potentially you've only got 10% of a protein you need. And I'm going to try and do something fancy flipping between slides now. But we know that you might have seen genetic reports from your testing, is that through evolution, some people have variable numbers of this SMN2 gene. So it's nothing to do with most people, everyone with 5q SMA doesn't have an SMN1 gene, but the number of SMN2 genes is the biggest but not the only factor about whether people are able without treatment to sit, to walk, to stand. And there are other factors, and people will have brothers and sisters with the same number of SMN2 copies, but some walk, some don't. So there is some other variables. But if we go back to this slide, you can see if you imagine that one copy of SMN2 gives you 10% protein, 2 might give you 23, might give you 34, might give you 40. I'm not sure that's backed in science, but it's a helpful way to think about it. And then with the treatments available in adults, both nusinersen and risdiplam have lots of differences, but they have one big similarity, is they both solve, whoa, we've lost the pointer, there we go. They both solve this problem. So the misprint is corrected to let your SMN2 gene create a full-length protein. So it's a very clever bit of biology to work out how to do that. So coming into the current treatment of the summary of where we are now, so we can think about what's happened in the future. Say the mechanism of action is similar, but of course the route of delivery is very different. If we talk about the nusinersen in the first place, that's a really big molecule. And that's because it's basically like a synthetic version of the RNA, and it matches into it, clicks into it, and gets it to make that proper transcript. And so because it's a really big molecule, it can't get across into the brain and into the spinal cord, and that's why you have to put it in with a lumbar puncture, initially with loading doses, and then every 4 months, and then it travels around the whole brain and spinal cord. I'll come to a bit more to complications in a minute, but a lot of it around the issue of the lumbar punctures, but it can sometimes drop some people's blood counts, and it has to be filtered out through the kidneys, which is why we check people's kidneys. Because it stays in the brain and the spinal cord, because we've said it can't get out, it doesn't interact with many other drugs. And I'll touch on fertility a bit more in the next slide. The risdiplam is different. It's a small molecule. So this is what drugs always used to be. All the drugs we're used to using for lots of other neurological conditions are chemical molecules, A-level chemistry, lots of hexagons and lines, and they create a shape which basically just makes the RNA transcribe better. So that's very exciting when they find it. And because it's a small molecule, it can be given as a liquid, and I think probably most people know now as a tablet as of a month or so ago, taken daily. So it goes throughout the whole body, so it can interact with some other drugs. And again, so that's sort of where we are now in September 25. And then I had to think about things that I think have been coming up in clinic, that I think about. I'm not saying I've got answers to, but that I think about. And the first one I thought about was fertility. So I think what I've got on this table is what we'll say on the product insert. And so this is what the drug companies would say about fertility in these drugs. That is very important to know what's regulated and what's allowed. So Biogen for Spinraza or nusinersen would say there's no data about whether this is safe or not. For risdiplam, they say they don't have any data, but there were some possible adverse events in pregnancy in animal models, and that is where a lot of research is done. And male fertility may be affected, so they recommend people use contraception, and including for 4 months after stopping the treatment for men, because it takes that time for the sperm to travel through. And sometimes people are offered, men to save their sperm before starting treatment to allow them to start a family without having to interrupt their treatment course. But I just thought it was worth thinking about that a little bit more, because as people stay on the drugs longer, and I've pulled out what I've found is relevant. So thinking about male fertility first and risdiplam, you can imagine there's a couple of different combinations here, aren't there? So, I mean, I think it is true, if slightly difficult, fact that it does look like in the population of men living with SMA, there are somewhat higher rates of infertility than the general population. That may be because the SMN1 protein does also have some role in how sperm either are produced or in how they can travel and move, which sperm need to do. And when the lab, I'm not entirely sure anyone's clear. I'm certainly not thinking I'm clear, maybe Channa is, that there's different ways where it could just interfere with how the sperm are produced, or it could actually interfere with the sperm to put misprints in it. And then you might be worried more about the baby that's made. But what has coming out in the literature on the side, and I am going to show you a few papers with references, not because it's a lesson or you need to them, but I think you've got a right to know there. And this is just a paper with 3 men who have conceived while taking risdiplam. So I think that tells you a few things. It certainly is possible. So taking risdiplam doesn't mean you don't need to use contraception if you don't want to conceive a child. So that's probably something that's important to know. One thing about clinical trials is they always exclude people who are trying to conceive. And so we will never get good clinical trial evidence for this. And I'll show you in a minute, there's a registry. So I think we need more research to think about it, and definitely talk to your doctor, your clinician, your team, if it's something that's important for you, and see what's happening. So nusinersen and female fertility. So nusinersen male fertility, there isn't a huge amount written about it. Because it doesn't cross the blood-brain barrier, one would thought it doesn't affect spermatogenesis, but that's not what it says in the brochure, but that's what it would seem sensible. And similarly for women living with SMA, because it doesn't cross the blood-brain barrier, although it will originally get broken down and filtered out through the kidneys, so it will go into the blood, but it's very unlikely to cross the placenta. And this is sort of the never clinical trial data. SMA REACH has been mentioned already today, and I think they have a registry, don't they, of anyone who becomes pregnant in any way, regardless of what happens to that. We would very much like to know your consent to be involved in that so we can get more data. But there's the odd case report coming out around the country of people using nusinersen during pregnancy, which would be with a big balance of discussion of risk and benefit with your clinician. But of course, pregnancy can be a time when it's impossible to be pregnant and not gain weight because the baby weighs stuff, and that can affect people's function. So I think something definitely to keep watching, keep discussing, keep acting. In terms of, so we've done risdiplam and female fertility. I couldn't find any literature of this. The only literature is around a very exciting but slightly different question of a lady who knew she had a baby that has SMA, and she took risdiplam, but then she wanted it to get to the baby because she wanted to boost the baby's function, so that's different. But I wanted to draw your attention to Roche having developed this registry. So this is the way to gather data. So I'll move from that topic now. I appreciate it may come back up in questions, and was going to look a bit about how good are these drugs in adults. What are they doing for them? Are they helpful? Where's that data? Because I think we have to remember that there wasn't initially any clinical trial data at all for risdiplam in anyone over 18. Of nusinersen over 18. There was some for risdiplam. So this is just this is only an example of people with type 3 SMA, to say that over a very, very long time, so 10, 20, 30, 40, I think over here we're at 60 years, function does decline very, very slowly. And I think that's very important because it means a treatment that stops that happening is a successful treatment. And this is different to children, because children without SMA, and hopefully with as well, they first of all just lie, then they sit, then they walk, and they run, they learn to ride a bike, and they join a sports team or something. That's not what adults do. The natural history for all adults, of course, not those with SMA, is that their motor function declines as they get older. It's true for everybody, perhaps more so. So I think we need to bear that in mind and look. And different studies have been coming out. There haven't been randomized clinical trials, but some countries, and this study here is sort of not Central Europe, but Germany, Switzerland, and Austria, putting all their patients together. And they've shown now over around 4 years that it continues to be helpful. Whoa, sorry, I thought there was another thing on that slide, but it seems there isn't. And these are the outcome measures that I'm sure lots of people on treatment have spent a lot of time doing. This is the Hammersmith. I don't think it matters. All the graphs fundamentally look the same. After sort of just over a year, just over 2 years, just over 3 years. And the ones above are better, the ones in the middle are stable. And of course, there's always some people that decline, whether that decline is less than it would have been otherwise, or whether it is hopefully not more, but the same, is hard without a randomized controlled trial to say. And then the other data, just to share, we do think about it, and a key theme, I think, in the panel discussion was around collaboration. This is when this type of review is called a meta-analysis and systematic review, and it's probably the ultimate in collaboration. It's where people take all the different studies. So we had the Germany, Switzerland, Austria, and there'll be studies from the US, and there won't be any published data from the UK at the moment because the Managed Access Agreement prevents us from publishing, but there will be when that's resolved. And they put it all together and try and analyse it. And so this is probably the biggest data set, 650 people, of which 40% were ambulatory, showing either stability or improvement over 4 years. So I think this is encouraging. In terms of risdiplam, there was original clinical trial data in adults, and all their trials are named after various types of small fish. The ones with adults in were sunfish and jewelfish. I don't know if anyone was able to participate in those. So we did have data, because it was been on the market a little bit longer, there's less of the meta-analysis data yet, but this is where they showed different improvements in small measure. This is the only one I could find more recently is just one centre, so not huge numbers of people, but asking interesting questions. I think, did you see benefit, linking again to this sort of patient-reported outcome measure, which is so important, we discussed earlier. Side effects, I think, is important. It's probably something I spend more and more time thinking about. You've started people on new medications. We knew what happened in the clinical trials, what happens in the real world, what's important. And I think the main things from the nusinersen side, I think for most people, are probably been related to the lumbar puncture. And I'll leave Channa to talk a bit more about ways to overcome that. I think there is still a signal about it being filtered through the kidneys, and most of us are monitoring that with blood tests. I'm sure everyone is. We certainly are when people have that treatment. Risdiplam, a few different things I think are coming out. I think the GI side effects are in the trial probably are real. They do happen. They do seem to resolve over time. And there's some other... It's hard, isn't it, for us to increasingly pick out what's about living with SMA and what's related directly to the drug, which is why we must report it around wound healing and some urinary and kidney stone infections. But at least people are looking at it. This actually comes from the FDA, which does collect a lot of data and been using the drugs a long time. I was sure someone was going to ask me this question, so I thought I'd put a slide up. Is one of the treatments better than the other? There's no head-to-head studies, and of course they're made by two different drug companies, so it's highly unlikely this will ever happen. They have the same mechanism of action, and I've just found 2 studies that give you the completely opposite answer. So one large meta-analysis that thought from China that thought the nusinersen was better, one systematic review only in type 1, so the relevance to people in this room, I'm not sure. Done by Roche. I think one always does have to think about conflicts of interest there, who thought that risdiplam were better. There's nothing clear, I think, at the moment. I thought another question I thought certainly people would ask, and it is certainly worth thinking about, isn't it, is combination treatment. This was quite a nice paper where somebody's gone through all the potential possibilities for everybody living with SMA, including children. So people who've had gene therapy before, after, and Dr. Scott was talking about bridging therapy. So there are a lot of these combinations. So the only possibilities really at the moment for adults would be to switch between nusinersen and risdiplam and back. And there's really only mainly published data at the moment of people switching from nusinersen to risdiplam, and I think this is simply to do with the order in which they were approved, both in terms of clinical trials internationally and in this country. And essentially it seems safe to do this, is the summary of the data, I think, is what we can say. I liked this. It was a very small study, but it was about the patient perception of switching, and it's about method of delivery is more convenient, and most people felt switching. And the reasons for switching were mainly around method of delivery, and yeah, I mean, that's the main part, I think. So that's something we think about. I think thinking about switching, this is a US paper that's come out recently about best practice, which has lots of nice pointing. But ideally, we talked, and I've put this graph up again, not to bring this, that the rate of change, if there is any, is very, very slow. And so if someone was having a very serious side effect, which is what they talk about here, then obviously treatment would be changed urgently. But otherwise, it is helpful probably to give the treatment a year, 2 years, 3 years, and this it's helpful to understand the effects before switching. And this is something that I know lots of people who worked with the managed access agreement is helpful to think about. So I didn't want to have this talk without talking about the importance of supportive care. This isn't all about drugs by any way, shape or form. And it is always very important to have a whole team around people with whatever's relevant at the time, maybe physiotherapy, maybe occupational therapy, speech and language, respiratory. But I understand there's an SMA care workshop later in the day, so that's why I haven't spent lots of time talking about that. So that was all I had to start with. And then I think, Channa, you're going to have a chat about some of the things that are coming up in the future. And then, unless anyone, I'm happy to take as anything burning question that's going to distract people from Channa's talk, I'm very happy to do that now, or we can have a bit of a longer discussion at the end. Channa looks keen. Burning. Just anything that's going to distract someone and not let them concentrate. I've said something that's upsetting or difficult. No.
Thank you, Claire, for setting the scene for the next talk. And thank you, SMA UK, for inviting us to share this information. So I'm Channa, as Claire mentioned. These are my disclosures. I set out some objectives to try and achieve and organize my talk. Firstly, I thought I'll talk about an overview of the treatment targets that we currently have and potential targets to develop new therapies and limitations in current treatments. I think Claire has already given a nice overview of this. And then I'll take you through some studies. Although there are no direct studies only in adults, there are a number of studies where there's a small proportion of adult patients included, or adult age group, that means 16 and above. And then I will also talk a little bit about non-drug related research developments, or I'll whet your appetite about it. So Claire nicely talked about the pathophysiology of SMA, and I just wanted to stress by putting this slide out that it is just not a motor neuronal disease, particularly in the type 1 SMA, the acute phase SMA, shall we call it. There is also impact on the heart, the small and the bones, the smooth muscle, and other organs other than the motor neuron. So it is important that when we consider research, we not only focus on the motor neuron, but we also need to look at the person as a whole. What are the therapies that we can do to modify the disease? What therapies can we do to help the complications that the patient or the persons with SMA will have? When you look at the current therapies, they target, as Claire mentioned, SMN1 gene. In SMA patients, there is a lack of it or deletion of it. So replacing it with onosumna gene is a strategy. And when or you modify the SMN2 splicing by risdiplam and nusinersen-like therapies, which modify the splicing but act in different ways to do that. And then there is also the whole host of other problems that's going on. There's a motor neuron in the spinal cord, and then it produces an axon that then goes and innervates the muscle. If you imagine the size of the motor neuron as a football, this long axon is about 7 football stadiums long. You can imagine how much internal milieu needs to be very, very well controlled. So there are various processes that happen within the cell. There are mitochondria, there is a maintenance of this long axon, and then you have this motor axon come and joins the muscle where there's a neuromuscular junction. So there are various therapies now being developed which are SMN targeting therapies, and then there is a whole set of therapies which people are developing, what we call complementary or non-SMN dependent therapies. So I'm going to talk to you about a few of these as well. And then the therapies in blue are the ones which we have already in our clinics. And there are some therapies which are non-SMN dependent, which have had clinical trials, but they're not in practice in clinic. So when you look at the challenges in the existing therapies, if you look at, for example, the gene therapy our pediatric patient population receive, this is mainly limited to type 1 SMA. And you might have heard that they have significant hepatic, liver, and heart-related side effects. And this is dependent on the amount of virus that we give into these patients. And then when the therapy is then felt to be not effective, what do we do in that situation has become a significant challenge for that group of patients. When it comes to nusinersen, there might be some of you who might be receiving nusinersen. May I have a show of hands who's receiving nusinersen or who have received nusinersen? A few. And risdiplam? Equal numbers. So when it comes to nusinersen, those who have nusinersen would experience that these are repeated lumbar punctures, and some of you who have complex spines, it is quite a challenging process to give it. And there can be complications as a result of the procedure. And what happens when people show that the nusinersen is probably not doing the job that it did, and what can we do next? These are all challenges. And then when it comes to risdiplam, it is a daily dosing therapy, and some people find it quite, shall we say, intrusive to have to take a medication every day. And for some patients, that is the only option they have because of the complications of the spine. And some of them may develop side effects like diarrhea or skin rashes, etc. One of the colleagues came and talked to me, a patient came and talked to me about a skin problem and what can I do after that. And again, in that population, you might not have a second option. So these are real challenges for our existing therapies. So how can we then overcome these therapies? When it comes to onosumna gene or SMN1 replacing gene therapy, there are some new developments where you can overcome the intravenous challenges by giving it into the intrathecal space. I'm trying to increase the awareness of these therapies, because one of my strategies in making sure that my adult SMA clinic or adult neuromuscular clinic is ready for new therapies is that to become aware of what's going on in the children or in the pediatric sector. Because like Clare said, nusinersen nor risdiplam were tested extensively in the adult patient population. Only Sunfish Part 2 had patients up to 25 years of age, but then the treatments did come to our clinics. So being aware of these therapies and what the pharmaceutical companies are doing with the regulatory bodies will give you an idea how soon these therapies may reach our clinics. So there are real potentials that some of these therapies could make their way to our clinics. So there are a couple of trials that looked into intrathecal onosomnogene treatment. We'll talk about that. And then when it comes to nusinersen, there are also a couple of ways that people are trying to develop new molecules that are long-acting and higher dose nusinersen trials to overcome some of the fluctuations or treatment effectiveness. And then the other thing that has increased momentum or gathered interest is the myostatin inhibitors. So there are particularly one myostatin inhibitor which has more specificity and is a targeted therapy. So bearing in mind this structure, I will talk to you about now the alternative treatment delivery methods in existing therapies. So with that, I would like to talk to you about an alternative method of delivering nusinersen for those who are actually receiving nusinersen or who can't access nusinersen because of difficulties in lumbar punctures. This study is called PERE study, and it has a second component called PERE-PK, PERE-PK, which is a pharmacokinetic study. Here, what we are investigating is whether we can put a catheter system. This is a port, and there's a catheter that goes into the spinal cord, and the port sits just under the skin, and everything is inside your body, and nothing is exposed out. So what you do is once that is done, you inject nusinersen through the port, and then it gets in through the catheter into the spinal cord. So this is an international multi-center study. In the UK, fortunately, we have one center. So in Sheffield, we are a center who accepts more patients who are more than 16 years of age. Unfortunately, there is no pediatric component to the study in the UK. And this is the study outline. The patients will come who are currently receiving nusinersen. They will have their bloods taken at 4 time points after their regular nusinersen treatment, and after that, before the next nusinersen treatment, in that 4-month period, those who are consenting will have the catheter port system inserted. Now, for that, patients will have to undergo general anesthesia, and it is a surgical procedure to have the port inserted. And then it is carried on with nusinersen treatment at every 4 months. The primary outcome is mainly looking at the safety and the feasibility of having port catheter system inserted. So if anyone is interested, please do come and talk to me after the session. And the next is I'm looking at some of my slides have gone missing. I was going to talk to you about the intrathecal gene therapy delivery clinical trial. There's a phase 3 study called STEER, which has recently concluded, and it showed that there was the study met the primary endpoint where there was an increase in Hammersmith motor function score. The study was mainly for type 2 patients, and there were patients included all the way up to age 16. There was no significant difference between the patients who received the treatment as opposed to those who had the placebo. The important thing was that there was a small proportion of patients who developed liver dysfunction and low platelets. most importantly, as neurologists, there were 2 patients who developed a sensory changes, what we call sensory ganglionopathy, and that can be interesting but very important side effect of gene therapy that we need to keep an eye on. So in the absence of those slides, I will move on to the next, which is on the long-acting forms of drugs or drugs that we can give at a higher dose to overcome the efficacy issues. So DEVOTE study is it has 3 arms. It was looking at giving high doses of nusinersen. Now, for example, you receive 12 milligrams of nusinersen as 4 loading doses and then every 4 months. In this study, they looked at whether you could receive much higher doses. Now, there were 3 parts. Part A were the unaffected volunteers, and then Part B was a double-blind control study, which was in the pediatric patients, and Part C is an open-label study, which included 40 patients, and there were a number of adults patients in that as well. So, a study showed a significant benefit in terms of the Hammersmith score, where there was a 1.2 to 1.4 improvement at 300 days. And they were giving doses of 50 milligrams. So you had a single loading dose of 50 milligrams and 28 milligrams every 4 months. So it's a significantly higher dose. One of the key things to look for was the side effects, and there was no significant difference of any major side effects. So high dose of nusinersen is a possibility in time to come, I hope. And then the ASCEND study is a study where they looked into a long-acting antisense oligonucleotide. We know that nusinersen is an ASO, and they developed an ASO where once you've given it, you only have to repeat it after another year. As in this study, they had patients included between 15 and 50, and clinicaltrials.gov.uk will have much more details about its inclusion criteria, etc. And as far as I know, there are no UK sites according to the clinicaltrials.gov. So there is also this opportunity for our patients, but this study, they are looking at those who have previously been treated with the risdiplam. Bigger pardon, I think I made a mistake there. So this ASCEND study is for those patients who have been previously treated with the risdiplam, and those people who you thought maybe either due to side effects or due to that there was inefficacy, then they can try this high dose of nusinersen. It is the salanersen, which is the long-acting nusinersen, which is a phase 1 study that has recently completed, which showed some positive motor outcomes in the pediatric age group. So this certainly becomes an opportunity for our patients. So in this study, they only studied between 6 months and 12 years. So when it comes to one-off treatments, okay, now I find my slides. This is the onosomnogene intrathecal treatment I was talking to you about, and this is the STEER study. It's called STEER, and it has 2 arms. One is the onosomnogene arm, other one is the sham control arm, and patients received a single treatment, and they were followed up for 52 weeks, and then that was the outcome. Primary outcome was to see whether there was a difference in the Hammersmith score. Again, in this study, they included patients of type 2 SMA, and they between age 2 and 18. So these are the key inclusion criteria. They have to have type 2 SMA and age between 2 and 18, and they should have also be able to complete the Hammersmith score. And the key thing about this therapy is that one of the exclusion criterion is the antibodies to AAV, adeno-associated virus. So if the titer was more than 1 in 50, then those people are excluded. Now this is a big unknown area for adult patients. We do not know the frequency of antibody positivity for this viral vector. So that might become an unmet need in the adult population. So we discussed about the primary endpoint of motor function score improvement, and they had 75 patients in the treatment arm and 51 in the sham. There's a 2-to-1 randomization, and you can see in this graph in orange is the sham control or the placebo, and the treated arm continued to show improvement until 52 weeks, where the primary endpoint was assessed, and there was 1.88 point change in the Hammersmith score. And there were several other endpoints, including the room, which showed a significant improvement of 1.52 points. And this was the side effects profile. Again, there was no significant change. There were few. In orange, sorry, in the blue triangle is the onasemnogene treated patients, and the sham were orange. So upper respiratory tract infections were seen a little bit more frequent in the treatment arm, but the rest were more common in the placebo group. So there was no significant concerning warnings. But this is the point that I wanted to raise with you, that there was 2.7%, in fact, 2 patients who had this sensory ganglionopathy or dorsal root ganglion like phenotype, which we need to keep an eye on. So in summary, the STEER study summary, it showed that there was a promise that there's a one-off intrathecal therapy in the pediatric patient group, and I understand that the Novartis are looking into a label for a much wider group. And then, although there was a positive motor function improvement and the side effect profile was not that different to the placebo, one needs to keep an eye on the longer term effects of this sensory dorsal root ganglion involvement. That brings me finally to the myostatin inhibitor story. Now, this is an interesting story. You may have heard about the mighty mouse, that's this guy, and the naturally occurring the blue cow. These are due to mutations in the myostatin gene. Now, myostatin is a very important member of a group of molecules called transforming growth factor beta. So this is a superfamily of molecules which control various functions in our cells. So myostatin particularly controls our muscle regeneration and proliferation. So there are a number of benefits to the human for modulating the myostatin, but particularly for muscle wasting diseases. There's a promise that interfering and changing myostatin could have benefits. And then also bodybuilding community, I hear, are using various forms of myostatin inhibitors. And there is also new focus on using myostatin inhibitors in weight loss related therapies associated muscle wasting. So there is an excitement in myostatin in various fields. So how does it work? So in our normal muscle, there are what we call a satellite pool of muscle cells. And there are cellular processes which then activate the satellite cell to create what we call a committed myoblast. So this cell is not still a muscle cell. It's a committed myoblast, a juvenile form of muscle cell. And then they undergo proliferation, that increase in numbers, and then they have to differentiate into muscle fibers or the proper muscle cells. Now this process is kept on check by myostatin. If you have more myostatin, then it inhibits this transition into committed to proliferation and proliferation to differentiation. So in the absence of myostatin, or when there's less myostatin, then this process happens at much more efficient manner to increase your muscle mass. So myostatin has a significant role to play during embryological development and during early childhood and adolescence. And then it is kept on check throughout your adult life. So normally the myostatin has a precursor called the pro-myostatin and a latent myostatin, and these levels are significantly low. But in muscle wasting diseases like SMA or inherited muscular dystrophies and things like liver disease and heart failure conditions, the myostatin levels go up. And then it causes loss of your muscle mass or thinning out. So what scientists have done is that they try and interfere this myostatin. So myostatin can be interfered at various levels. At the active form of myostatin then acts on this receptor called ActR2B, and that then creates increase in proliferation of the muscles. Inhibition of the proliferation of the muscles, and muscle volume goes down. But in the therapeutic world, what they do is they inhibit the myostatin. So therefore, there is a signal cascade that increases the muscle regeneration and proliferation. But most of the targets are targeting the active myostatin. You may remember that I said that myostatin is a part of a superfamily of molecules called transforming growth factors. Now, these transforming growth factors have many other functions, including metabolism and how genes express themselves. So if you target the myostatin, there's a possibility that there is cross-reaction and off-target effects and increased side effects. And this has been the case with several myostatin inhibitors. But apitegromab targets a precursor molecule of the myostatin, therefore overcoming some of these side effects. So it is quite an exciting time for myostatin inhibitors. Right. My slide has become huge because there has been some myostatin problem there. Fortunately, I remember some of these things. So there are 3 drugs currently: apitegromab, entaldigromab alpha, and GYM329. So over here, apitegromab is from the study is called Sapphire from Scholar Rock, and there's a study from Biohaven. This has now stopped. And Manatee study is Roche where the myostatin was added on to risdiplam. So let me take you through this. So apitegromab has 2 studies. The phase 2 study called Topaz and Sapphire is a phase 3 study. And in the phase 2 study, it showed that it was fairly well tolerated, and there was an improvement in the patients who received apitegromab. There was increase in motor function and no significant serious side effects. So based on that, they developed the phase 3 study, and these are the top line results for you. And the patient group was between 2 to 12. There were 2 subgroups, 2 to 12 and 13 to 21. They looked at 2 sets of doses, 10 milligrams, 20 milligrams, and in 13 to 21, which is some of the adolescent and adult patients could be, they used 20 milligrams. And you can see here that both doses, 20 and 10 milligrams, increased the content of the latent myostatin. Now, you remember that if you block the early levels of myostatin, then the precursor levels will go up. So it basically tells you that it is engaging the target. And when you look at the motor function, you can see this is the placebo, and that's the patients who received the myostatin, that there was an increase in motor function compared to the placebo. So they showed that there was an increase in motor function. So when you look at the side effect profile, this is a very busy slide, but you can take my word that there was no significant signal difference between the placebo and the patient population. So take-home messages for the myostatin in adults is that I'm still cautious about this, but I think there is a potential that muscle-targeted therapies can benefit our patients, and safety data appeared to be comparable with the placebo, but there was slightly more pyrexia. But the long-term follow-up data is essential in this group of patients because we are learning about it. Now, before I end, I would like to give a preamble to the fact that there are so much focus on the pharmaceutical therapies, but we also need to look at other measures of helping our patients and improving their quality of life. This is an example of something like that, called the Cybernic therapy hybrid assistive limb device. Now, this device is, if you want to read about it, there is a nice article here. It's from a Japanese group where they developed this suit, and it has sensors, biomechanical sensors, which senses your muscle activity as you just try to do something. It senses and it gives you a boost of power. There is a video of a person who's lifting up 3 or 4 bags of cement, and it gives superhuman powers, apparently. And for patients with muscle weakness or muscle weakening diseases, this suit can be helpful to I guess, engage in your physiotherapy and do some activities with more extra support. So what I would like to discuss, if we have time, it would be to discuss that the drugs to target root cause of SMN deficiency might have its own deficiencies, such as we probably will need to look at alternative methods of delivering this drug, like how we've seen in PEER study through a port catheter system. We may want to explore the long-acting drugs or higher doses of the drug so that our patients will have longer lasting greater benefits. And then gene therapy, I think this is a space to look out for potential for its application in adult patients. And then there are drugs that target other pathways which are non-SMN dependent, such as the myostatin inhibitor, and there's another drug called chloride channel 1 inhibitor, which is again it had some adult patients and is completing the study very recently. And finally, the bone health, cardiac health, reproductive health related studies that Clare showed, and exercise and physical activity and exoskeletal devices. These are all things that we need to do extra studies to how we can improve the outcomes for our patients. With that, thank you very much. Clare, I wondered whether you want to come up. Please fire away any questions and we'll try our best to answer. Over there, 2 questions.
Shall I move round? Intrathecal replacement forms. If you've had spinal therapy, spinal fusions, would that
Okay. With the intrathecal ports therapy, if you've had spinal fusion years ago, would that affect how it actually be? Is it possible to have that port fitted?
Yeah, I think there's a poster already that we have collected data for 10 patients in the UK, so 6 adults and 4 pediatric patients, and a number of them have already had spinal rods. And your short answer to your question is yes, you can.
So spinal fusion is slightly different from rods. So I mean total fusion, because that's the problem. We moved off neurosinusin to risdiplam because the actual port was so small that they left the hole, but the guy couldn't actually get it in, even with like all the X-rays and all the other bits and pieces in the actual theatre. It became impossible, and they ended up just getting. What did you have? They used to have headaches and all sorts of problems because it was leaking all the time. So that's why we ended up moving to risdiplam.
Without going into detail, yes, you still can, because there is a drilling process. You drill in through the bone and put it in. I've sat with my patients, for 6 of them, in the theatre, how they do it, so that I can tell the patient what they probably go through. Oh.
Am I right in thinking that the amount of SMN protein varies or can vary with external factors during the course of a lifetime? So if one's got an acute illness or puberty or menopause, it goes up and down, and that therefore there's an argument for individualized, tailored, varied dosage of risdiplam or nusinersen?
So that's a very interesting question, because a number of our patients, Clare, please share your experience as well. They do complain of fluctuating benefit from nusinersen, particularly when they come towards the 4th month, just before they have nusinersen, they notice that there's a dip. Now, gene expression can have multiple factors that influence it. But I'm not acutely aware of any studies looking at the changes in SMN1 level within the CSF of these patients. So, great point.
Yeah, I think it's a very important point, and I think we probably don't know enough about it at all. Because probably, 10, 20 years ago, if you'd asked, was SMN protein important in developing, so in an embryo developing, in a baby development, in a baby in their first year of life, we'd said, yes, it's very, very important. Do adult motor neurons need SMN protein? I don't know we know for certain. It would suggest that they probably do, but to what extent, we don't know. And do they need it constantly, or do they need it during developmental repair? I don't think there's enough basic science to know, unless you've seen literature. I haven't, Channa.
I think SMN1 protein plays a role in adult, because there are adult patients who continue to decline with over time, and type 3 patients can sometimes develop disease around age 16, 17, and type 4 patients after 20 years of age. So whether the levels fluctuate with stress and other external factors, I can only imagine that it would, but I'm not aware of scientific evidence recently in the CSF SMN levels. Apologies for that. Question over there?
Hello. It strikes me that my mouse was actually doing exercises to build all those muscles. So with all the treatment we've been told about, is physiotherapy also considered, and exercise also considered, the complementary treatment, just like the exoskeletons and everything else? And if it is there any pressure being put on NHS in general not to neglect physiotherapy in adult patients, because we are at the stage of transition and we've been told by physiotherapists, oh, well, your physiotherapy is going to finish now when you're 18.
I think you raise a very important point, because it's so important. We have a separate session on exercise by Robert, Katie, and Anna after lunch. Yes. So I couldn't agree with you more, but there'll be more information from my esteemed physiotherapy colleagues.
Yes.
So I think the answer is that exercise and activity is clearly important, right? There's no point replacing your SMN protein, your myostatin, if it's not complemented by activity. I guess there's then a philosophical question about whether that is done hands-on by a physiotherapist every day, every week, every month, every year, or whether it's something that can be done with AI or apps, or how it's done. So I'm sure these are things you'll cover in the session, but there's no doubt that activity is vital. Yeah, and the differences between how the NHS view expensive drug funding streams and physiotherapy, it's a big topic. Yeah, indeed. I wouldn't want to take resources away from children, though. I mean, I think we Katie, need a mic over. Oh.
Hiya. My question's about patient data collection that we put in ourselves. It often asks about improvements that we've seen, but I'm of the age now where I'm going through the menopause, and my concern is that I'm not asked about that, and whether that will have an impact on my strength, which is unrelated to SMA, which might mean I end up being removed from the treatment.
I mean, I think it comes back to the point you said, that there is changes, and I think that maybe the point I made, I think we're making the same point, that I will get weaker as I get older. I don't have SMA, but I will, and this needs to be factored into the experience of adults living with SMA, and there's still benefit, right? Even if things are slightly worse, they might be less worse than they would have been with aging. Menopause is included in that for women, but I think there is similarly an experience for everyone as they age. I think you make a very good point. I'm not sure I have an answer to it.
The other answer is exactly what Claire mentioned, and what you're asking is extremely true, and we have seen patients in our cohort who notice changes in their motor function when they go through certain changes in their lives. And of course, there is also the age-related sarcopenia factor that's associated with it. I think that's one of the reasons why we may also need to think of muscle modulating medications.
think the reason I asked was because I'm not asked specifically, are you going through menopause? So it might not be picked up that may be a reason, or it might not be picked up that I've plateaued, but in reality I've actually declined.
That's reasonable. Are you asked your age and your sex, or?
I can't remember.
Yeah, we should look into it. I think it's a reasonable point. Thank you.
Just to add that through the registry, when you enter your information through the prompts, there's that global impression of change, which is your opportunity to rate and put a narrative to it. So thanks to the information that you all put through the registry, we will be able to advocate for these other benefits of the treatment and share this narrative with NICE. So please do report any other findings that you feel are not collected in the usual assessments through the prompts in the registry.
What was that? Yeah, sorry. Thanks, Katie.
Thank you. It was just going back to the ports that you mentioned earlier, and I noticed that you said part of the procedure was to drill into the spine to install it. And obviously that's quite invasive, and the spinal column is quite a sensitive area, and I was just wondering if out of the patients you mentioned who'd had it done, had anyone had side effects from that? Has it gone wrong for anyone, or is it quite safe on the whole?
Yeah, a good question. So the previous question to yours was that in patients who have their spine fused, how do you get into their CSF space? In those situations, there's a certain form of drilling that is required. Now, this is not necessarily similar to drilling a big wall with a jackhammer. It's not that kind of drilling. There's a very fine neurosurgical drilling. It happens under patient is under anesthesia. But there are a number of patients who you don't need to do that because their spines are not fused, and patients do say, I don't want to have lumbar punctures, can I have a lumbar port? And in those situations, it has not involved the kind of drilling that we are talking about. Procedure, lumbar puncture is invasive. Of course, this lumbar port catheter system insertion is also invasive. In the 10 patients, one patient we had to take the catheter off because patient developed this infection around the skin where the port was put in. The others few of them have had headaches soon after the procedure, but then they're doing really well now. Yeah.
Over here on the left.
Hello. We're sitting here in an adult forum and we're still talking about typings. Does it really matter when we get to an adult stage whether we're type 1, as my son was always diagnosed as, and is 20, or type 2, or type 3, non-ambulatory? Because he's often excluded from various clinical trials, and is often I'm not saying overlooked because he's not at the clinic, but I just wanted your thought about that, because to me SMA now is a sort of a continuum, really.
I mean, I think I agree that the terminology changes. It happens in other conditions. It's a good thing. And you can imagine my clinic header letters, the future will say, you know, what would I want to know? I'd want to know probably SMN2 copy number, age of onset of symptoms, or age of onset of treatment, if that was pre-symptomatic or symptomatic. And I'd also want to know current function. And people often use lying, sitting, standing, ambulatory as a way for that. So clinically, I agree. What clinical trials choose to do, to why it is relevant and why we still use it, is probably partly because I haven't updated my slides, but and it takes a long time for terminology to change in textbooks and so on. We've seen this sort of epilepsy MS, when they change terminology, it takes time. But they can choose to include or not include whatever they like in a clinical trial, and my hands are then tied, as anyone who went through the managed access agreement will know. It was very, very difficult. I don't know if you want to add anything, Channa. I think you make a good point, and I think we will change on the basis, as I say, of age of onset of symptoms, current function, what treatments people have had, when they were diagnosed, and hopefully things usually do change with it, with a bit of a lag in the clinical trial field, I think, in my experience of other conditions, which is important.
Yeah, I think, as Claire said, categorization of populations for clinical trials is when the types categorization occurred, and then it became rather in the clinical practice an academic process until the drugs became available, and then the NICE said type 1 got this, type 2 got this, etc. But going forwards, you're right, I think SMA and copy number and whether what treatments they have had might be more important way of categorizing the patients.
Thank you. Thank you for amazing two presentations. I have two questions, if I may ask, right? One is about the upcoming treatments or the treatments under investigation, under research. So we're seeing there are add-on therapies being trialed in the Sapphire study and, let's say, muscle-targeting treatments, but also as regarding causative treatments, there's this new drug intrathecal gene therapy coming. So this will likely be marketed or as also treatment for adults, which is like people who are present here. The question is about switching, right? So if it is treatment for adults, so the only treatment for adults, and people are being treated currently with either nusinersen or risdiplam. So do we have data on switching, on what effects will it have on the patients? And why I'm asking is, we see treatments like nusinersen and risdiplam, the drug concentration is so high in the CSF that it essentially reaches every cell. Every neuronal cell. With gene therapy, we see there's only approximately 60 to 70% of cells get transduced. While it's not a problem in children because of the plasticity of motor neurons or plasticity of the entire central nervous system, this could theoretically cause problems in adults. So where the nerves do not really so easily take over the function of other nerves, right? So we can see a situation where approximately 40% of motor neurons will not receive treatment after switching and will deteriorate, right? Let's say will get atrophied, will stop functioning. And right now the treatment is going through regulatory approvals. Are you as clinicians highlighting this? Are you, let's say, urging the company or trying to look or trying to generate data, or urging the company to generate data, or what's your take on it? This is my first question.
Mm-hmm. Okay. I think you raised a very, very important question. And what is not available to us as clinicians is, yes, we know that about 30 to 60% of the neurons get transduced by the gene therapy treatment, and there is several-fold increase in SMN levels when you give risdiplam, to some similar extent with nusinersen, but no one has shared what assay they use to measure SMN levels. And how do we decide that when someone is not responding to a treatment, that they have had the adequate increase in amount of SMN levels, and in spite of that, they are deteriorating. Now, if that was the case, I don't see any point in adding anything else because you have already increased SMN and we are not seeing a clinical benefit, but we don't have those answers. I think the regulatory approach would be someone who is on risdiplam, either they are getting worse because the risdiplam is not doing the job, or they're having side effects and they need an alternative therapy. And patient choice will be such an important thing when you have 3 drugs, and then probably you will need to go through some biomarkers like neurofilament levels, and regulatory bodies will be wanting to know, in addition to your clinical subgrouping, what do you use any biomarkers? If someone's neurofilament levels are going up, for example, in adults it's quite low, but you might need to find something similar to indicate that there is more active motor neuron degeneration happening. So in these patients you need to treat again or add another drug. But there is a lot of unmet or gaps in knowledge about how these drugs increase SMN level. Can we monitor that? and how can we subgroup our patients to predict who might respond to which drug. Nusinersen story is fairly straightforward. If someone is struggling with nusinersen, you can't access it, or there are spinal complications, then one might think that, okay, either long-acting nusinersen or perhaps intrathecal gene therapy. So I hope I answered your question, but I don't have definitive reply to give, but there are highlighting even bigger gaps in knowledge.
Yeah, thank you. The thing is, you said people might benefit from a different therapy if they are not benefiting from, let's say, from intrathecal gene therapy. But the question is whether the regulators, the NHS will allow that, because the treatment will be funded. Let's say you can have several treatments funded for a patient at a time. So if the company says, okay, we offer it and we guarantee that some effects for 5 years, but then the patient doesn't respond, doesn't have such a good response, whether there will be funding available to go to another very expensive treatment, because we know the price of Spinraza and Evrysdi right now. So there would be we need to also keep in mind this regulatory framework here, right? Not just the science. Okay, let's switch patients to something that worked before. And this kind of leads into the second question, SMA types. We saw how we still use SMA types routinely on a daily basis, and even though we've seen how much harm it has caused with nice recommendations for nusinersen, when it was recommended for specific types for patients with who had a history. It was based on their historical functional score and not on the current score at the start of treatment. So, and we know now that SMA is a spectrum disease. So is there any kind of discussion ongoing to move away from the concept of types altogether, right? Because types, we know that they are not a good predictor of disease trajectory anymore. They are not a good predictor of treatment response either. So why keeping them? Just to give a tool to let's say, NICE and regulators worldwide to approve or refuse treatment based on this outdated concept? Is there any discussion ongoing to lead on getting rid of the types? Thank you.
I think it is a process that's already happening. People are moving away, or not moving away, but people are discussing about other ways of categorizing. For example, we try to subdivide patients by functional status. But when it comes to NICE, I think it's important to remember how they look at the cost effectiveness of a drug. They apply that to the utilities gained, and how you define that would be based on a subgroup. And evidence we have so far from natural history studies, etc., is based upon the type, the so-called historical type. But short answer to your question, yes, people are. There's a big discussion in the community that should we be using type 1, 2, 3. This sounds very arbitrary, milestone-based categorizing method, or whether we should have other alternative measures of subgrouping our patients. So I think that is a philosophical, but also a very important practical question going forwards. We have been informed that we are
20 minutes into our hour-long lunch break. I think we've got a question here and one there, and then we'll have to. Oh, hang on. All right, and then no more, if that's all right. Just because the lunch will all be eaten by the children.
We've just got a very quick point here.
Sorry, did you want to?
Okay.
Really quickly, Channa can't disclose this. I'm one of his patients that has the intrathecal port. I've had it for about 2 years. If anybody wants to hear a patient's perspective, I'm happy for you to approach me. I'm here all weekend. Mine was quick.
Thank you. That's great. Over here?
Last one and then lunch.
Sorry to be the ultimate. You mentioned the Roche myostatin and risdiplam combination, but I didn't hear you say how far advanced that was or report anything else. Is there any way we can access how that's going on? Because that sounded like a very interesting study.
I would say one of the Roche colleagues is here. You probably could approach him and get some latest details. I did ask for the additional slides, but some companies don't want to appear to be promoting their drugs.
Perfectly understandable. Will he be wearing a white carnation or something? Can I?
He's
got a blue jacket on.
He's a blue jacket on.
Yeah.
Try and point him out.
Light blue. Okay.
I think perhaps we can call it to an end.
Thank you very much.
Can you just join me in thanking our two speakers? Thank you.